Hello, are you able to see the screen?
Yes, sir.
Yes, sir.
Yeah. So, okay, very good morning to everybody. So, I'm continuing with this. Last time we had dealt about the tumors, pre-malignant conditions of the oral cavity and all. So, this time, wherein we have to see each and every tumor. So, we are going to go detail because we have time. So, every class you can go for 2 or 3 tumors. So, this time we are going to complete tumors of the oral cavity. So, oral cavity tumors, as you could see here, so they are number 1 buccal mucosa. So, buccal mucosa. Number 2 is floor of the mouth. Number 3 is tongue. Number 4 is retromolar trigone. Number 5 is maxillary alveolus and hard palate, that is hard palate growths. Number 6 is mandibular alveolus. Number 7 is lips. As easy to remember, take the lips, okay. Take the upper jaw, that is hard palate and maxilla. Take the lower jaw, that is mandible. So these three are those things. And retromolar trigone, when you open the mouth, so you go just in front of the anterior pillar. This is anterior pillar, posterior pillar. This is soft palate. This is the posterior pillar. This is anterior pillar. So this is the cheek mucosa. So whatever the triangle in front of the mandible is there, that is called as retromolar trigone. So retromolar trigone is this area. So that is the retromolar trigone. I'm not going to details of the anatomy. We'll deal each and every anatomy specifically. And tongue, as you could see, so oral tongue. You open the mouth, oral tongue till the level of circumvallate papilla, that will become the tongue. Okay. Next, floor of the mouth is just below tongue. When the tongue is lifted like this, so when the tongue is lifted like this, whatever is there below the floor of the mouth, that's called as floor of the mouth. And buccal mucosa. Especially talking about the buccal mucosa, we will be dealing about floor of the mouth and buccal mucosa cancers today in detail. So it's like a high-end level lecture. So most of the points will be understood, and then I think if a question comes, you can write the answer. It will be for 2 marks or 4 marks question. They are not directly important for you as a ENT student, but you have a basic idea. Why? Because tumors of the head and neck are going very high, and you should have a concept of what is that. Okay. So what is that buccal mucosa? Actually, if you take the anatomy of the buccal mucosa, so when you take the buccal mucosa, you should take, so once you open your mouth like this, so you open your mouth like this. I told you till the level of anterpillar, posterior. This is a soft palate. So you are taking this particular anterpillar here as a posterior boundary, and you mark it like this. Okay. So how do you mark a line here in front? This is a retromolar trigone. That is, here the mandible will be there. So in front of the ramus of the mandible will be the retromolar trigone. So here will be the in front of the anterior pillar. How do you mark 2 lines like here? You take the gingiva like this. That is, third molar will be here. The third molar, distobuccal aspect of the third molar till the level of the same position in the mandible. If you take the mandible here, here the third molar will be there. So third molar to third molar. This is the maxillary tuberosity. Distal buccal aspect of the third molar. So of the mandible. So maxilla to mandible, you draw a line like this. In front of it, from the angle of the mouth till this level, all this will become the buccal mucosa. All this will become the buccal mucosa. This will become the buccal mucosa. What is the lined by? It's lined by non-keratinized stratified squamous epithelium. So keratin is very less keratin. So upper aerodigestive tract tumors, are all squamous cell carcinomas. Squamous cell carcinomas by pathology. Why? Because so you have a thick aerodigestive tract for food. You have to have thick mucosa for which keratinization is must. Okay. So food will not be much focused upon this buccal mucosa. So because of that reason, the keratin is thinner. Okay, keratin is thinner. Okay. Whereas on the tongue, the keratin is thicker. Whereas on the anterior pillar and posterior pillar, the keratin is thicker. Posterior pharyngeal wall, the keratin is thicker. In such situations, the keratin is more. So upper aerodigestive tract is lined by squamous cells. So stratified squamous epithelium skin only. So you should have basic idea of that. So this is the non-keratinized stratified squamous epithelium, where is varied thicknesses. What is the bulk of the cheek made up of? Bulk of the cheek is made up of buccinator muscle. Bulk of the cheek is made up of buccinator muscle. Bulk of the cheek is made up of buccinator muscle. What is the thickness of the cheek? 1 to 3 centimeters. 1 to 3 centimeters. What is the nerve supply? Buccinator, buccal branch of the mandibular division of the trigeminal nerve. Buccal branch of the mandibular division of the trigeminal nerve is the nerve supply. Okay. So what are the arteries that are supplying? That is facial artery, the most important thing. So what are the lymph nodes that are going lymph nodes of the buccal cavity are facial nodes. All these things we'll be seeing. Okay, we'll be seeing in the picture. Okay, so when you take, so you start with the tumors of the oral cavity, take a quotation, very important. Make accurate incisions so that the whole tumor, whenever there is a tumor, you have to remove the whole of the tumor so that we do not leave even a single root also. This is said by Galen in 280. So that is nearly 1800 years back he said this statement. Okay. So when you take oral cavity is the uppermost part of the aerodigestive tract. So digestive tract, oral cavity, the food enters through this. Started the mucocutaneous junction of the lips and the vermilion border. So whenever there is, so lips and vermilion border, you should have an idea about this lips and vermilion border. So you should have this idea. This is skin and this is the lips. So these lips are with chin or with the mucosa only. So this forms the junction, the vermilion border. So where does the oral cavity extend from? So these are all anatomical facts you should be able to know. So this is the upper lip and this is the lower lip. And you take inside, so till the level of soft palate, and this is the hard palate. This is the hard palate and soft palate junction. So this is the hard palate and soft palate junction. This is the alveolar complex with all 8 teeth on one side and other 8 teeth on the other side. So till the level of hard palate and soft palate junction, it is the hard palate and soft palate junction. It is superiorly, this part forms the oral cavity. And here, what does it form? Anterior fossa. I told you 2 pillars will be there. Anterior pillar will form this fossa. So this is anterior fossa laterally. So and the junction of anterior 2/3 and posterior 1/3 of the tongue. If you take the tongue here, for example, anterior 2/3 and posterior 1/3 marked by circumvallate papillae. So this forms the oral tongue and the other one forms the oropharyngeal tongue. The one behind forms the oropharyngeal tongue. So oral cavity includes till the junction of hard palate, till the junction of circumvallate papillae, and laterally is the anterior pillars. That you should have it in mind. So laterally is the anterior pillars. So tongue you should take, and all these things are understanding for anatomy. So oral cavity is the stratified squamous epithelium. I already told you, based on keratinization it will be there. Okay. Primary tumors of the oral cavity. So oral cavity, if you take directly, oral cavity tumors can come from mucosa, can come from salivary glands, especially minor salivary glands. Especially there are nearly 1200 minor salivary glands all over the upper aerodigestive tract. UADT is called as upper aerodigestive tract. Nearly 1200 salivary glands, minor salivary glands. Other than parotid, 2 parotids, 2 submental, submandibular, 2 sublingual. These are the major salivary glands. These are minor salivary glands. Minor salivary glands, the specialty of these minor salivary glands, they most commonly form carcinomas only. There are less number of benign tumors. They are more commonly forming carcinomas. Less number of benign tumors, more of carcinomas. Neurovascular structures also can give rise to tumors. Bones such as maxilla and mandible. So bones such as maxilla and mandible. So when these are there, you have to go for maxillectomy and mandibulectomy. When bone is involved, you have to go maxillectomy and mandibulectomy. Mandibulectomy can be rim mandibulectomy or segmental mandibulectomy. So if you take mandible like this, so if a part of the mandible is being removed, it is called as rim maxillectomy. If a segment itself is removed, it is called as segmental mandibulectomy. This is rim mandibulectomy. This is segmental mandibulectomy. So 90% of the time they can be dental tumors also. They can be dental tumors. So these are all the components of the oral cavity. That's why they can form any tumor. 90% are squamous cell carcinoma. What is the commonest tumor? It is squamous cell carcinoma. All over the world, 3 lakh people are with oral cancer per every year. 3 lakh people. 3 lakh people with cancer, oral cancer every year. It is the 8th most common malignancy. Oral cancer is the 8th most common malignancy is the oral cancer. There is a geographical variation, oral cancer being the 3rd most common, especially if you take India, Pakistan, etc., this Bangladesh, and this particular Sri Lanka, Southeast Asian region. Southeast Asian region, especially it is the Southeast Asian region, especially it is the 3rd most common cancer. Important, very important. 3rd most common cancer in Southeast Asian region is oral cancer. That is oral cavity or whatever it is, that buccal cancer or all those things, oral cancer, 3rd most common. The incidence of, especially in England, it is 6 per lakh or 4 per lakh in female. Okay. But whereas in Southeast Asian region, it is 25 per lakh. So 25, almost 4 times. Southeast Asian region, it is 25 per lakh, almost 4 times. It is almost 4 times to England. You remember, this is English textbook which I have made it from. It is 4 times. That's the registration is raised. The cases are raising. Why? Because at least in the last 30 years, particularly in those under 65 years, also getting. Normally, cancer is a disease more than like that. But nowadays, even less than 65 years, people also getting this cancer. Why? Because it is increased alcohol. So alcohol is having less amount of strength as far as food part is concerned, that is nutrition part is concerned. It helps in increasing the dissolution of the toxins and entrance into the mucosa. Mucosa to submucosa they enter, and this alcohol forms aldehyde which leads to free radical damage. Alcohol forms aldehyde which leads to free radical damage. Free radical damage is more. So alcohol is a bad food and it only it is an intoxicant. It causes kick. That is the only reason people take it. So better to ban alcohol. Better to not to take alcohol, so that you can avoid most of the cancers and also other lifestyle related diseases. Only it protects from the coronary artery disease, which is a meager thing. Oral cancer is more common in males, okay, and 6th and 7th decade, 60s and 70s, they will be more common, okay. Although incidence of oral cancer is increasing in young people, even in females also nowadays it is increasing because even females are not leaving alcohol, they are also drinking a lot of LPG drinkers in females also. So even the trend, tradition, culture, everything is going towards even female alcoholism, which is not at all good for health and for other generations, which is not at all good even as per the if you take it cultural aspect or whatever it is. So diseases are more common because females have to bear child and they should teach the next generation. They should not take alcohol is one of the cultural practices in our country, but it is also getting more for nowadays. Smoking and alcohol nowadays, even females are also smoking. Smoking and alcohol consumption are the major etiological factors. So they are largely preventable cancers. Smoking and alcohol, smoking and alcohol, smoking and alcohol. But if you take that, so if you smoke, oral cancer is detected, it is confined to oral mucosa. If the oral mucosa only involved, they have got very good survival rate. That is nearly 80% survival rate. 80% survival rate is there for oral mucosa. But if it is going and spreading to the nearby tissues like mandibular, maxilla, so if you detect them early, you can have 80% survival rate. They are going to mandibular and maxilla, it goes to 40%. And once again, if it is going to distant metastasis, that is distant metastasis, distant spread, it is going to become 20%. The 80 becomes 40, becomes 20%. Okay. Early presentation with oral cancer is associated with improved prognosis. So early presentation very good, less extensive treatment and attempt to cure. You can get it, especially T1 tumor, something like that. You can get very good cure. So we'll see all the staging and all. So research is required regarding selected opportunistic screening. You need to go for opportunistic screening. Screening is very important, like in breast cancer, as you do. So there are some salivary tests, of course, which are not stratified correctly right now. So you need to improve the expertise and resources. So you need to have proper planning in the coming future so that you can screen them well. Early diagnosis, screen them well with early diagnosis and prompt treatment. As you know in SPM, that early diagnosis can be done. For the patient to receive optimal management, truly multidisciplinary team. It is not like only oncologists will treat. So surgical oncology, medical oncology, and radiation oncology. As you know, surgical therapy, so medical therapy and radiation therapy are the three treatment modalities for any cancer. So this is all done, regional cancers. Now going into buccal mucosa per se. It is a mucosa. I already told you mucosa lining of the inner surface of the cheek. So if you take the cheek like this, it will become this one till the level of anterior pillar. You should take in front of the retromolar trigon. So that is maxillary tuberosity to distobuccal aspect of the third mandibular molar. So this is the molar of the mandible and this is the molar of the maxilla. You will draw a line like this. Because maxillary tuberosity there and the third molar here. In front of it is the buccal mucosa. So it extends from oral commissure anteriorly to retromolar trigon posteriorly. I already told you this is the retromolar trigon. So this is the retromolar trigon region. As you know, this region is retromolar trigon. So this is oral commissure and retromolar trigon anteriorly posteriorly. What is the junction between the buccal mucosa and retromolar trigon? How do you draw this? I already told you. Buccal mucosa and retromolar. Anatomically, you have to remember everything. drawn from maxillary tuberosity. I already told you that is maxillary tuberosity to distobuccal aspect of the mandibular third molar. Distobuccal aspect of the mandibular third molar. If you take mandible, this becomes the third molar. From here to here, if you draw a line, in front will be the buccal mucosa, behind will be the retromolar triangle. The inferior and superior boundaries. What are the inferior boundary and superior boundaries? So when you take the lip like this and open it, so there are maxillary teeth like this and then mandibular teeth like this. This becomes the gingivobuccal sulcus, and this is the gingivobuccal sulcus of the upper jaw, and this is gingivobuccal sulcus of the lower jaw, upper jaw and lower jaw. So gingivobuccal sulci, they are called as gingivobuccal sulci. It is not exposed to masticatory, less masticatory load. It is only helpful to drive the food from cheek towards the oral cavity. So it is non-keratinized stratified squamous epithelium. This is lined by non-keratinized stratified squamous epithelium. The mucosa is firmly attached. The mucosa is firmly attached here and then to the buccinator muscle. What is the chief component of the cheek? It is nothing but buccinator muscle. Buccinator muscle. What are the other things that are there? Minor salivary glands are there within the cheek. I told you many minor salivary glands all over the cheek. And parotid duct is opening at the upper second molar. Upper second molar, is it or not? So U2M, upper or first or second maxillary molar tooth. Upper second molar tooth. So duct of the parotid duct will be opening. Okay. Parotid duct, entrance duct will be opening on there. Okay. Next is sensory innervation is buccal branch. I already told you mandibular division. Mandibular division is third, 5-3. 5-3 is the mandibular division of the trigeminal nerve. Okay, lymphatic drainage is most important is the facial nodes. Number 1, number 2 will be the submandibular nodes. Number 3 will be the deep cervical nodes. Facial nodes, submandibular nodes, and deep cervical nodes. The thickness of the cheek is 1 to 3 centimeters. Thickness of the cheek is 1 to 3 centimeters. Thickness of the cheek is 1 to 3 centimeters. Epidemiology. So, what is the importance of the buccal cancers? Buccal mucosa cancers. Buccal mucosa cancers are the most commonest. It is 40% of the oral cancers in India. For example, India, this is called as ABC, alveobuccal cancer. Alveolobuccal cancer. If you take this is the buccal, and this is the mandible, and this is the mandibular molar, and this junction where they keep the betel quid. So betel quid. So they eat the pan. Is it or not? They put it here under the top level and they try to spit it there. So betel quid pan, pan masala. This contrasts with the North America. Of course, not important for us. It is only 10% there, but in India it is 40%. 40% chance of mucosal growth. Okay, consumption of betel nut is very important. It is culturally embedded. You should see that they are accepting singing the songs, all these songs. Culturally accepted thing. So it is a site for predilection. So what are the important ingredients of betel nut, pan or pan masala? It depends. So sometimes it will be piper betel leaf. I told you last time also piper betel leaf. Piper betel leaf. So if you, of course, you should try it with green color piper betel Okay, sorry for the delay. So there is some phone call. Hello. Hello.
Yes, sir.
Yeah, we're continuing. So Erica nut, as you know, among all this, piper beetle leaf you are chewing, and there is slaked lime. Okay, this is called a sunnam in Telugu. Okay, slaked lime, spices. You put all those things, dalchin, and then all those lavanga, everything. And tobacco is also there in that. Okay, based on different areas, they put different things. Okay. Some people eat fire pawns also, but especially this erica nut. Okay, this erica nut you will having this one. Tambulam erica nut will be there. That is leading to oral submucous fibrosis. Erica nut is leading to oral submucous fibrosis. For many years, tobacco was thought to be carcinogenic, but however, previously it was thought tobacco, but now erica nut, as I already told you, is the most important thing. The oral submucous fibrosis, wherein it becomes thick and thick. Christmas will be there, and then I already told about oral submucous fibrosis last class. Okay. Individuals regarding whichever side they keep, they have the tumor on that side. Okay. Smoking and alcohol along with betel chewing. Okay. If betel chewing is not there, smoking and alcohol will be the reason for the buccal growth. Okay. The male to female preponderance is 1:1 in Western countries. In India, it is more, of course. Southeast Asia, it depends upon consumption of betel quid. In India, it is 4:1, and in Taiwan, especially, it is 27:1 when you take male to female. So, buccal carcinoma, you need 40 years of age, although it may occur in younger because betel chewing is increasing in younger, and alcohol is also being increasing in younger generations. Okay. Buccal carcinoma may be described as any growth, can be a verrucous lesion, can be exophytic like a tree, exophytic lesion, or ulcero-infiltrate. It can infiltrate with like an ulcer. Okay, ulcero-infiltrate. So verrucous, exophytic, ulcer-infiltrated. They may present with pain, mass, ulcer, and trismus. As you know, trismus is associated with oral mucous fibrosis. Okay, pain, intraoral mass, ulcer, and trismus. Patient who chew the beetle in the areas of leukoplakia, I already told you, erythroleukopenia has got a chance for carcinoma nearly 16 to 18 times. Okay, leukoplakia. Leukoplakia has got 2x of chances of cancer, 16 times. Erythroleukopenia is red color patch. It is 16 to 18 times, very important. So it leads to oral submucous fibrosis, and trismus will be there, and it leads to detection of invasive squamous cell carcinoma. Invasive squamous cell carcinoma difficult. So if you have oral submucous fibrosis, it blocks the seeing of cancer. So oral submucous fibrosis forms a layer on that, and it inhibits us to see the cancer. So we might be delaying in the diagnosis. If there is advancement in the buccal cancer, it can go to skin, mandible, and maxilla. It can go to, I already told you, upper jaw, it can go to lower jaw. So it forms T4 stage. Okay, there are stages like T1, T2, T3, T4, which I will show you at the end. So T1 is less than 2 centimeters, T2 is 2 to 4 centimeters. Okay, T3 is more than 4 centimeters. But whereas T4 is T4A and T4B. Okay, T4A and T4B. So T4A and T4B I am showing you. So T4A, wherein you can have this skin, mandible, and maxilla involvement. This all becomes, or even the nose skin of the nose. All this becomes T4A. So T4B is the worst untreatable disease. T4B, when it extends to internal carotid or masticatory spaces. Okay, masticatory spaces, or it can go to pterygoid plates like this. It can go inside of the body. So it will be T4B. So based on these only, so not unusual for the patient. So if you advanced diseases, they go into 40% stage 3 and stage 4 diseases. So initially you go for T stage, you go for N stage, you go for meta stage. T is the tumor stage, N is node stage, M is metastasis stage. After doing that, you go for group staging. So there is finally group staging. As you could see, the group staging can be done in that manner. As I already told you, I'll just tell you how group staging can be done. So in case if you get T1, T2, T3, T4 as a table, you can put is N0, N1, N2, okay, and N3. You can put it like a table like this, object table like this. So once you take this, you should have an understanding of how you are writing this one. So 1, 2, 3, 4, okay, 3 you can write, and all fours, okay, rest all are fours. So you can say as stage 1. This is stage 1, this is stage 2, stage 3, stage 4. So if T1 and N0, it becomes stage 1. So if it is, for example, T2 and N0, it becomes stage 2. Okay, T3 and N0, it becomes stage 3. T4 and N0, it becomes stage 4. Easy to remember like this. Okay, so you have to understand. At the end, I will once again tell that. Okay, so you can make n number of combinations with this. So stage 3 and stage 4, 40% of the patients they present with stage 3 and stage 4 disease. Next, palpable lymphadenopathy on presentation may be as high as 57%. You might have lymph nodes in 57% of the cases and T3, T4 lesions. So you can have stage 3, stage 4 in 40% of the cases, lymph nodes in 57% of the cases. Of course, these percentages are not important for you. Just I'm telling. There is something called occult nodal metastasis in 26% of cases. Occult node is a suddenly discovered node. Okay, suddenly discovered node. You don't know that node is there, but suddenly discovered node. 26% who are at N0. You think that he is N0, node 0 only, but you have occult nodal metastasis in 26% of the cases. Occult nodal metastasis in 26% of the cases. If tumor is bigger than T2, it is poorly differentiated. So have poor lymphocytic response. What is differentiation? Differentiation is resemblance with mother epithelium, resemblance with parent epithelium. For example, here the squamous epithelium is there, which is resembling the squamous epithelium. If squamous epithelium is not resembling the squamous epithelium and becoming like, for example, columnar epithelium, it becomes poorly differentiated. So well differentiated, moderate differentiated, poorly differentiated, anaplastic. These are the 4 things that are there: well differentiated, moderately differentiated, poorly differentiated, and anaplastic. Well differentiated, moderately differentiated, poorly differentiated, and anaplastic. These are the 4 things that are there based on differentiation. Tumors thicker than 5 millimeters are likely to have cervical metastasis. Thickness, as you could see, this is the thickness of the tumor. For example, if it is more than 5 millimeters, it can have cervical metastasis. Okay, these tumors are usually well differentiated. If less than T2, they can be well differentiated. How do you work up? You have to go for biopsy of the dose. Okay, you have to include the depth. So depth of the tumor will be helpful in the management of the neck. So for tumor, you have to remove the tumor. Number 1. Number 2 is address the neck. Address the neck. So it is called as neck dissection. Address the neck is neck dissection. So because the tumor is having cells in the particular site and it metastasis to the neck nodes. For the tumor, and you have to address the neck. That is, you have to go for neck dissection. It's called as neck dissection. So remove the primary tumor and remove the lymph nodes also. Remove the tumor and remove the lymph nodes also. That is called as neck dissection. So depth of the tumor will help in the management of neck. So buccal carcinoma may rapidly extend to the adjacent side. Why? Because there is mandible and maxilla nearby. Mandible and maxilla and skin also there. Okay, that is one which is helping in the spread towards the mandible and maxilla. That is infiltrating tumors. You have to go for CT and MRI for imaging. And if you have to see the depth of the primary, you have to go for ultrasound scan. And you can also see the cervical lymphadenopathy with USG neck, ultrasonogram of the neck. You have to go for cervical lymphadenopathy. Treatment is early stage of disease like T1 and T2 surgery is the best option. Okay. If you are going with T3 and T4, you have to go for post-operative radiotherapy. You have to go for post-operative radiotherapy in the case of selected patients. Okay. T1, T2 disease can be treated perorally. Through the oral cavity itself, you can remove the tumor and then you treat them. Whereas T3 and T4 disease, you require facial access incision. Number 1, you have to cut on the face. Number 2, you have to go for maxillectomy or mandibulectomy. As you know, mandible and maxilla also can be. Well, you have to go for maxilla or mandibulectomy. You have to remove that. I told you T3, T4, especially T4, they are involving the bone. Okay. Primary tumor should be resected. What is the resection margin? It is 1 centimeter margin. 1 centimeter is the resection margin. And if skin is also involved, you have to go for 2 centimeters. Skin is also involved, you have to go for 2 centimeter margin. So buccinator muscle is a component of cheek. So you try to spare the buccinator as much as possible because it loses the contour of the cheek. When contour of the cheek is lost, you will have difficulty in swallowing and speech. Speech and swallowing. So better spare the buccinator if possible. Whenever in oncology treatment in oncology surgery, if possible, spare the lesion. If possible, spare the structure. For example, if it is invaded by cancer, remove the structure. So most of the times you have to spare the structure, but if any structure is invaded, you can remove. If invasion is there, you have to remove the structure. Invasion is there, you have to remove the structure. Very importantly, this is very important point. Invasion is there, you have to remove the structure. If you are that structure can be anything. For example, in parotid tumors, if facial nerve is involved, you can remove the structure. There is no other option. So there should not be any oncological compromise. There is a word called as oncological compromise should not be there. Oncological compromise should not be there. Should not be there. The parotid duct may be needed and repositioned or ligated. If needed, you have to remove the parotid duct. If it is preserved, you can reposition and ligation. Skin also. So skin is involved, 2 centimeter margin is needed. So along with the specimen, you have to take out the skin. So maxilla, mandible if required. So mandible, if you are removing the mandible completely, a segment is removed, it is called a segmental mandiblectomy. If you are taking a part of it, it is called a remove mandiblectomy. Remove mandiblectomy. T1 tumors, okay. T1 is less than 2 centimeters. Less than 2 centimeters. T1 is less than 2 centimeters. Size is 2 centimeters, less than 2 centimeters. They are resected. So for any cancer, you have to go for resection. Number one, you have to remove that cancer. Number two is rehabilitation. Rehabilitation. These are the words in oncology you should know. So resection and rehabilitation. And you can go it by primary closure itself. Primary closure. What is primary closure? During surgery, for example, less than 2 centimeters, you can remove the tumor. For example, if cheek is involved like this, you have to remove this tumor, and then you can oppose these margins and then suture it. That is called as primary closure. That is during surgery only will be closed. Healing by secondary intention. What is secondary intention? You have removed the cheek tumor, for example, and then leave it like that. It might heal by itself. That is called as secondary intention can be considered. However, trismus will be there unless vigorous mouth opening exercise. If you are trying to suture the cheek tightly, there will be trismus will be there. So you should give exercise for that. And something called as split thickness skin graft. They are called as SSG, split thickness skin graft. That is a part of complete epidermis part of dermis. For example, 1/3 of the dermis is involved. You have to remove that from some other side. For example, from the thigh, take the skin and then put it there to stabilize the graft. Be useful. That is called as split thickness skin graft. The use of a skin graft to reconstruct the deeper resection may leave the cheek with a potential poor aesthetics. So cheek is something which is related to beauty also, aesthetic component also. Okay, aesthetic components also. Keep it in mind. So whether it is functional or not. Number one, whether it is aesthetic or not. So what are the flaps that are used? What is flap? Flap carries a blood vessel along with it for a blood supply. For a blood supply. For a blood supply. Flap carries a blood vessel along with for a blood supply. Buccal fat pad, number one. Temporoparietal facial flap. So temporalis muscle, parietal region, and temporoparietal fascia is also useful. Temporoparietal facial flap can be there. Temporoparietal facial flap can be used. So microvascular free flap reconstruction. Microvascular free flap reconstruction is microvascular free flap means so it is detached from the body and then it is put somewhere else. So radial free flap, forearm part, radial forearm free flap can be used, or anterolateral thigh flap can be used in the cheek. So if external skin is involved, so flaps are bipadal. If skin is also involved, you have to go for bipadal flaps. Okay, bipadal. Just these are all just words. Don't worry if you don't know also. Bipadal flap. In T4 tumors, so T4 tumors, as I told you, skin of the cheek. Okay, skin of the cheek, mandible, and maxilla are all involved. You can go for composite free flap. Free flap is detached from the body. Compositely, it has got a bone or a cartilage or something. Okay, that is called a composite free flap reconstruction can be done. So what is the example? Radial free forearm flap for give better post-operative mouth opening. Mouth opening is better with radial forearm flap than a split skin graft or buccal pad. This is giving less opening, so radial free forearm flap is better for this. So radiotherapy, what would you do? T1 and T2 you have to go for radiotherapy. T1 and T2 you can go for single modality, just radiotherapy is enough in some selected tumors. Okay. However, this particular hospital, Memorial Sloan Kettering, which is standard for cancer, and they said that better surgery is done than radiotherapy. Surgery is better. Surgery is better than radiotherapy. Less surgery is more. Brachytherapy, you are putting, for example, iridium 192 or gold. A small gold is inside the tumor, though it leads to radiation and it decreases the tumor size. So that is called a brachytherapy. You are putting an intracavitary brachytherapy or external beam irradiation. You can go for example, patient sits here and then there is a beam of radiation from outside. That is called as EBRT, external beam radiotherapy. So this is called as brachytherapy, BT, or external beam radiotherapy. These are types of radiotherapies that are there. So how do you address? So you have to treat the primary and you have to address the neck. That is a concept of neck cancer. Okay, primary has to be treated, neck has to be treated. Regional spread, where does it occur? Buccal cavity, it spreads to level 1 submental and submandibular, upper jugular-digastric. Okay, upper jugular-digastric. That is tonsil node. That is tonsil node, as you know. So behind, below and behind the angle of the mind, if you take the angle of sternocleidomastoid like this, here will be this, and here will be submental and submandibular nodes. These are the important nodes, level 1 and level 2. So if your palpable lymph nodes are there or pathological nodes are there, you need to go for something called as comprehensive neck dissection. The surgery done for lymph nodes is called as neck dissection. So if pathological nodes are there, there is something called as selective neck dissection. Selective neck dissection 1 to 3, level 1 to 3, selective neck dissection. Just remember the word selective neck dissection 1 to 3. Whatever the lymph nodes are involved, you can go for selective neck dissection. Nodes in the region of facial artery, because so this facial artery arises from this particular carotid triangle. It travels like this and then buccinator, for example. There are nodes on this facial artery, so they have to be removed. So you should keep it in mind. So 45 millimeter size, you have to go for elective neck dissection. Okay. So in some institutes they go for 4 millimeters also, they go for elective neck dissection. So what is the treatment for this neck nodes is neck dissection, just remember like that. And something called as post-operative, after surgery, go for radiation, that is called as post-operative radiotherapy. That is called as post-operative radiotherapy. What are the indicators when you have to give post-operative radiotherapy? If 2 nodes are present, more than 2 nodes, more than or equal to 2 lymph nodes are present, go for extracapsular spread is there, or positive margins, or stage 3 or stage 4 disease. Stage 3 or stage 4 disease, these are all the indications for post-operative radiotherapy. More than 2 nodes, extracapsular spread, positive margins, stage 3 and stage 4 disease. So benefit of post-operative radiotherapy is noted already. Even in stage 1 and stage 2 disease, 10 millimeters thicker, they go for post-operative radiotherapy. They say like that. Even in stage 1 and stage 2, 10 millimeters thick, they go for post-operative radiotherapy. Recurrence rate. How is the recurrence rate for buccal cancers? It is 26 to 80%. So of course, carotid duct and buccinator are not significant. They are not significant for recurrence. Recurrence rate is 80%. So what are the recurrence is based on tumor thickness and tumor differentiation. Tumor thickness and tumor differentiation. Recurrence is based on tumor thickness and tumor differentiation. Prognosis: buccal cancers are aggressive. Alveobuccal cancers are all aggressive, very dangerous. So you have to treat early stage 21 only. So 5 years survival depends upon treatment modality. What are the factors for survival? The factors for survival depends on regional metastasis, extracapsular spread, tumor thickness, skin involvement. It becomes T4, positive margins, stage of the disease, and recurrence of the disease. These are all the factors of the potential survival of buccal cancers. Okay, just keep it in mind. The buccal cancers is over right now. Next, we are going to floor of the mouth. So actually, very fast we'll be dealing all these things. So there are different regions of the mouth. These are all given in your textbook. Not very important for exam, but you should be having basic idea as an ENT student. So where is the floor of the mouth? Anatomy. We are going to take surgical anatomy. Floor of the mouth is the mucosal lining of the anterior and lateral floor of the mouth. So when you take this mandible like this, for example, tongue is like this. So here is a retromolar trigone. In front is the antrepillar. This is the retromolar trigone. This becomes the antrepillar. This is the antrepillar. So this is also antrepillar on the side. So from below the tongue, all over is the floor of the mouth. So this is the frenulum of the tongue, as you know. Here opens the submandibular sublingual salivary glands, and then from here to here, lateral part and medial part, midline part, all these things become the floor of the mouth. So anterior and lateral floor of the mouth. So it is bounded anteriorly by the mandibular alveolus. If you take mandible, this is the alveolus of the mandible where teeth are present. So laterally is the mandibular alveolus. Posteriorly by the anterior tonsillar pillars. I already told you from tonsillar pillars. If you draw like this, so this is the mandible, and this becomes the tonsillar pillar. Posteriorly is the anterior pillar that is forming the boundary. This is the mandibular alveolus, which is forming the lateral boundary. Here will be the tongue. Medially, the floor of the mouth merges with ventral and lateral aspects of the tongue. So, tongue, if you take, for example, this is the ventral part of the tongue, as you know. So, here will be the opening of submandibular sublingual ducts. You take the dorsum of the tongue. So, dorsum, tip, lateral part, and ventral part. So, what are the parts of the tongue? Dorsum, tip, lateral part, and ventral part. Dorsum, tip, lateral part, and ventral part. The floor of the mouth is lined by non-keratinized. Once again, non-keratinized stratified squamous epithelium, similar to the buccal mucosa, but with less dense submucosa. The submucosa is very less. Submucosa is very less amount of submucosa, very less amount of submucosa. The underlying the mucosa lie the minor salivary glands, everywhere there. Sublingual glands, you have got sublingual glands, you have got the submandibular ducts. What are the important nerves that are present? Hypoglossal nerve, 12th cranial nerve, and lingual nerve, which is a branch of 5th cranial nerve, lingual branch, mandibular division of 5th cranial nerve, and genioglossus muscle. Genioglossus muscle. What are the intrinsic muscles of the tongue? So genioglossus, diaglossus, and styloglossus, and peltoglossus. Okay. So extrinsic muscle. I'm sorry. Extrinsic muscles of the tongue is genioglossus, diaglossus, styloglossus, and peltoglossus. Supplied by means of vagus. Rest are supplied by means of hypoglossal. So intrinsic muscles are superior, inferior, transverse, and vertical. So these are the intrinsic muscles of the tongue. So tongue has got these many muscles. Okay. So when you say this genioglossus is also in genioglossus from the this particular mandible, genial tubercle, it goes like this and then it forms the tongue like this. Okay. So there is the genioglossus muscle. These structures are located in area bounded by mylohyoid muscle laterally. If you take an hypoglossal muscle medially. So all these structures are located. When you take the mandible like this, the mandible is having a floor which is having mylohyoid muscle like this. So mylohyoid muscle becomes a lateral boundary for this, and hypoglossal muscle becomes a medial boundary. So hypoglossal muscle becomes a medial boundary. So mylohyoid laterally and hypoglossal medially. I'll just put the pictures of this in the group. You can say see, and all these are very important for understanding the anatomy. The submandibular duct enter to the lingual frenulum. So you should know that submandibular is open. So submandibular gland opens separately and sublingual glands open separately, or they can combinedly open. Submandibular duct, okay. So is Wharton's duct, and sublingual duct is called as Bartholin's duct. They can open separately or as a together. Okay, Bartholin's duct. All these things you should keep it in mind. Sensory innervation is lingual branch as lingual. So there are two important nerves, lingual nerve and hypoglossal nerve. Okay, in the floor of the mouth, there are two important nerves, lingual nerve and hypoglossal nerve. Hypoglossal nerve branch of 5-3. Okay, so 5-3, that is mandibular division of the trigeminal nerve, as you know that. So lymph nodes, how is the lymphatic supply? Anteriorly, it is going to submental nodes. Anteriorly, it is going to submental nodes, and laterally, it is going to submandibular nodes. Okay, so laterally they go to submandibular nodes. Anteriorly, they go to the nodes. So every time when you take a structure in the body, the midline structures are drained bilaterally by the lymph nodes. Midline is bilateral. Midline is bilateral. Midline is drained bilaterally. One more important structure here is the lingual lymph nodes in the floor of the mouth above the mylohyoid. So lingual lymph nodes above the mylohyoid. If you take the mandible like this, there is a muscle called the mylohyoid completely occupying the floor of the mouth. So lingual lymph nodes are present above the mylohyoid. So lingual lymph nodes are present at above the level of mylohyoid. Lingual nodes, they are above the mylohyoid. So they are to be managed in the tumors of the mouth. So epidemiology, floor of the mouth is common for cancer, nearly 33% of the oral cancer. So previously it was 40%, buccal cancers is 40%, floor of the mouth is nearly 33% of the cancers occur at this side. So because of pooling of the saliva, there is saliva pooling, the dissolved carcinogens and the lack of keratinized epithelium. Okay. Keratinized epithelium, so submucosa is thin. The submucosa is thin, therefore less amount of protection. Within the anatomical side, the tumors are more common anteriorly. When you take the floor of the mouth like this, they are more common anteriorly, they are more common. Anteriorly, they are more common. Floor of the mouth occurs in carcinoma occurs in men 60 to 70 years male, more commonly present. As oral cancer has a strong association with smoking and alcohol, very important. They try to put the smoke and alcohol at the level of floor of the mouth. Presentation, how they say that is a small area, so they extend to the tongue and mandible. Most commonly, floor of the mouth cancers are there, they extend to the tongue or they extend to the mandible. They are nearby. They present with ulcer or sore or obstructed. Submandibular gland is opening there, therefore any tumor is there, it infiltrates it. It leads to obstruction of the submandibular gland. That is, they will be having pain while chewing, and there will be difficulty, burning sensation, pain, ulcers, etc. All these will be there. So for every tumor, leukoplakia is pre-malignant condition, very important. I told you leukoplakia is 2% nearly, erythroplakia is 8%, leukoerythroplakia is 18%. Okay, both are there, it is 18%. There are chances for pre-malignant condition, pre-malignancy. So site is different at different places. So most of the times they present with advanced disease. Half of the tumors are present with advanced disease. Lymphadenopathy is present in 40%. Half of the patients are almost present with lymphadenopathy, almost 22%. Zero. We think that the count is zero, but they present with actual metastasis. You don't know. Subclinical metastasis. Subclinically, they have got metastasis. So 28, almost 30% are bilateral. Why? Because the anterior tumors are more common, so they go bilateral. Any midline structure they go bilateral. Almost 30% are bilateral. Or they are well to moderately differentiated. I told you what is differentiation. How do you work up? So should follow any regular protocol. So particularly important, larger floor of the mouth tumors, assessment of invasion. You should say invasion of the tongue or mandible is very important. Whether the tongue is invaded or not, you should see. Mandible is invaded or not, you should see. So submucosa is very loose. It is a poor barrier for spread of the tumor, as I already told you. How is the treatment done? Aggressive treatment is needed. 1 centimeter margin you should resect. Surgery you should resect. And if, for example, there will be positive or close margins even in 47% of the resections. Okay, positive or close margins even in the 47% of resections, despite the use of intraoperative frozen section. They will use a technique called as frozen section, whether the tumor is having margins or not. There is an intraoperative frozen section. Many of floor of the mouth tumors are infiltrative, so they will be having positive margins. The margins will be positive. If it is having infiltratability, positive margins. So 1 centimeter is considered is okay. If you take out the tumor along with 1 centimeter normal tissue, it is okay. But sometimes they need 2 centimeters also. So early extension of the floor of the mouth into tongue and mandible is very important. May require, if mandible is involved, as I told you, rim or segmental mandibulectomy you need to do. Surgical resection of floor of the mouth will involve resection of submandibular ducts also. That's why, because submandibular ducts are also eroded by the tumor, floor of the mouth tumor. So you have to reset the margin away from the orifice, okay. In smaller resections, at least 3 millimeters duct should be taken to ensure surgical clearance. 3 millimeters of the duct should be removed because they think that dysplasia might enter inside it. Submandibular duct is of great importance if neck dissection is not being conducted. For example, if neck dissection is not being done, submandibular duct should be managed properly. If not, there is a residual tumor. So stricture of the duct will help in the inhibition of function of the gland and difficulty in differentiating the potential submandibular swelling. So you will have submandibular swelling if the functioning of the gland. For example, the duct is blocked, there is a swelling of the submandibular gland. So that is also their problem. So duct should be transected obliquely and minimize the stricture formation. So transected obliquely, if your duct has to be cut, it has to be transected obliquely for preventing the stricture formation. Sometimes they are marsupialized. The duct is opened up and then marsupialized and stitched to the floor of the mouth. So you should see that lingual nerves are preserved, and secondary intention you can go for split thickness skin graft also can be done. So reconstruction, how do you do reconstruction? Nasolabial or facial artery related myomucosal flap in a edentulous patient. So myomucosal flap, facial artery related myomucosal flap you should use. It's called a facial artery myomucosal flap for floor of the mouth. If neck dissection is required, you have to go for microvascular reconstruction. Neck dissection is required, microvascular reconstruction. Two teams are required. So reconstruction, resection is by oncologist and reconstruction is by plastic surgeon. Reconstruction is by plastic surgeon. So what are the things that can be done? Radial forearm free flap can be done. If needed, it can become a composite flap. Like bone and cartilage also can be added. Bone and cartilage also can be added. A prefabricated fascio-mucosal free flap also can be used. You can use fibula also for the reconstruction of mandible. Okay, it is superior one. Fibula is very important, especially because the flexibility of the skin is limited there. You can use scapula also with 2 skin paddles. Scapula is used, you can go for 2 skin paddles. So radiotherapy, how do you go the radiotherapy? Radiotherapy, it is done by brachytherapy, that is you are putting an implant inside the tumor or external implant in the tumor or external radiotherapy you could have in T1, T2, it is good. But unfortunately, there is something called as osteoradionecrosis. If you do radiotherapy, the mandible gets necrosed, called as osteoradionecrosis within 10 years. So they think that radiotherapy is okay or not. So T3, T4 lesions, anyhow, higher end, every time T3, T4 you get, you have to go for surgery in the post-operative radiotherapy. How do you address the neck? Floor of the mouth, you go Hello.
Yes, sir.
Yeah. We are at the end of the lecture. Almost 5 minutes it will be over. So if the floor of the mouth is involved, you should preserve the mylohyoid, hyoglossus, genioglossus if possible. And you should lingual lymph nodes should be cleared accordingly. Lingual lymph nodes, I told you, at the level of mylohyoid, they will be there. So whether you have to go for elective neck dissection or not is based on tumor size. So T2 or greater, you should go for selective neck dissection. Selective neck dissection means you have to go for 1, 2, 3. If needed, 4 is also added. You are selecting the lymph nodes and then removing. That is called a selective neck dissection. Just for your level, remember like that. Sometimes for T1 also you have to go for. So minimum T2 is there. You have to go for neck dissection is a rule. Okay. Minimum T2 is there. You have to go for radiotherapy, post-operative radiotherapy. It is a rule. Something like that you have to remember. Okay. So 4 millimeters thickness. That is a generally critical thickness of tumor. If 4 millimeters of tumor is there, you have to go for a neck dissection, elective neck dissection. Neck dissection has to be done. Since occult metastasis, the chances are 20%. There are silent metastasis, 20% chances are there, you have to go for neck dissection. So cervical metastasis is 20% chances are there. As thin as 2 millimeters tumor also will have cervical metastasis. So if 1.5 millimeters tumor is there, you have to go for neck dissection. It is very important. So T1 is less than 2 centimeters. Is it or not? Even in T1 also some people say go for neck dissection. So what is post-operative radiotherapy? When 2 or more involved nodes are there, extra capsular spread is there, positive margins is there, stage 3, stage 4 is there, you have to go for post-operative radiotherapy. 2 or more nodes. Beneficial role of port has been demonstrated. What is the recurrence? It is 55%. So recurrence is based on tumor size, number 1, margin status, number 2, tumor thickness, and advanced nodal disease. Prognosis is 76%. Okay, factors that influence the survival, they are number 1, node status, thickness, margin status, recurrence. Node, thickness, margin, and recurrence. So this ends the floor of the mouth. So next time we'll go for tongue carcinoma, mandible, maxilla, okay, alveolus of the mandible and maxilla, and then later on we'll go for this particular retromolar trigone, and that will be ending the lesson for the next class. Okay, so you should be able to know at least the basics of these important things are the anatomy, etc. Anatomy is very important, so you should have that idea about anatomy. Then you will be able to understand ENT better, so that at least you can write these answers. This will be 2 marks to 4 marks only, not very important. Previous class is very important. This class and next class is averagely important. You have to have idea about this. Thank you very much for your concentration.